Thank you to the organizing bodies for putting on a great conference. And it's really, truly an honor to be here. And Mario, you invited me, so I'm honored to be here. And I figured I'd do something to honor you today for my talk. I'm going to do this talk, not naked, don't worry. In Mario's national team sweater. So I got set up beautifully by Christian because he went over a little bit of the groin strain incidents in sports. Then we're going to talk a little bit about identifying risk factors for return to play, and is there evidence for those risk factors? We're going to go over a bunch of sports, my sport, which I've done some work in and published some research in, but also soccer, American football, and Australian rules. What are the keys to success and rehabilitation of those acute strains? And what are the factors that play into return to play? A lot of lost time happens in sport because of groin strains. Christian did a great job going over how many sports have a long-standing incidence rate of groin strains, both acute and chronic. If you look at this hallmark study here by Emery et al., great study, excellent. Over a course of 8 years, documented 617 groin abdominal strains. But what the problem is with this study is that it clumps any type of groin pain together. Even this great study out of Scandinavia looking at soccer players, where they looked at over 500, close to 500 soccer players, male and female. They saw injuries, they looked at lost time, bunch of stuff. But once again, hip and groin injuries are all clumped together. So what are we to do? I've been asked to talk about the adductor strains, and even with adductor strains, there's chronic adductor strains and acute adductor strains. And if you look into the literature, you get overlapping conditions. And in fact, this is what we all see. I'm in the clinic treating patients every single day, and no one comes in with just a groin strain. They have a little bit of abductor weakness. They might have a little bit of FAI, some sort of abdominal or sportsman's hernia or something like that. We have to be aware of that. So I implore folks who are going to go out and start studying and doing research in this area, or starting up new research, is to group these injuries separately so that we can actually study adductor strains versus sportsman hernias versus FAIs. So I've been given the task of doing adductor muscle strains. So screening for risk factors. Hopefully this is not one of the risk factors, but these may play a factor. In terms of playing surface conditions, Orchard did a great study where he looked at Australian rules football and found greater injury incidence in football when it's played in warm and drier climates. When other authors looked at soccer, indoor versus outdoor, they found no increased risk in indoor versus outdoor play. A lot of speculation has been discussed on turf versus grass and adductor strains. No one's found anything if it's more risk on turf or grass, but what some authors found in American football is there was a lower extremity injury risk was higher on artificial turf versus grass. Now in sport of ice hockey, there's been some talk, but no good clinical evidence. Sports Illustrated is not a good medical journal, I know. But if you go around the NHL or around the league, they talk about soft ice versus hard ice. And what they talk about the, oh boy, anything that will go wrong does go wrong. They talk about hard ice versus soft ice. And the players that play down south in Florida say it's harder to push off because the ice is softer. The players that play in northern Canada and Edmonton tell us the ice is very hard. It's easy to push off. I don't feel myself using my adductors as much. But there's no hard data exists on that. Another possible risk factor is footwear choice. And nothing's been shown in terms of adductor strains in footwear choice, but certainly this edge cleat shown on the bottom here has shown a higher incident rate of ACL tears with the edge cleat versus the randomized spikes in the bottom of the sole of the top cleat. In terms of ice hockey, there's this thing called the skate hollow. And people thought that the hollow is you have an edge, an inside edge, and an outside edge of both skates. The hollow is the depth in the middle. And each player has a specific hollow that they like their hollow. And it was thought that a hollow, deep or shallow, would cause a higher incidence of adductor strains. And in fact, when they did the study and grouped the standard deviation above and below the average, there was no evidence to support that it was predictive of injury. Experience has shown to show increased risk for injury in both soccer and in Australian rules football. But we know we need experience to win one of those. That's a Stanley Cup on the right. We need experienced players and to guide our younger players for that. So is it experience or the veterans just playing a little bit more? Because veterans have a 5 times greater risk in the NHL of sustaining an adductor strain. But is it an effective age or increased exposure? Because we know those veterans play more. We have to be aware of that. Our older players, those veterans, adductors, stiffer or weaker? I'm not sure we know that. We know that they have probably a more likelihood of a history of a previous adductor strain. Off-season training plays a role in Australian rules football. A faster planned agility score was associated with an increased risk of groin strains in that population they studied in Australian rules football. It's actually preventative in ice hockey. When ice hockey players come into camp and they've skated 18 times on the off-season, it decreases their risk about 3 times. But we know that the strongest predictor of an adductor strain is a previous groin strain. It's been shown in many sports by many authors. But now we get to the physical tests. What can we test physically? How can we look at these players to return them to sport safely or even prevent injury in the first place? Range of motion. Range of motion has been looked at in soccer by Arnson, and a decrease of hip adductor motion was associated with a subsequent adductor strain. Verall found it in total hip range of motion. Total hip range of motion rotation was associated with an increased risk for an adductor strain. We actually looked at it along with Emery and ice hockey players and found that it was not a risk factor for a subsequent adductor strain. Flexibility did not play a role in an adductor strain. We did not, fairly enough though, we did not look at hip rotation. That's something that we're studying right now, whether hip rotation, internal and external rotation, is an impact on a future adductor strain. Now, what Christian did so nicely earlier, half an hour earlier now, by the way, but that's all right. He told us about his recent study that just got published in the Orthopedic Journal of Sports Medicine just last week, and he found that eccentric weakness, not isometric weakness, was a predictor of return to play and a predictor of groin strain. Although in Australian rules football, Taylor et al. Showed that reduced adductor squeeze force was a risk factor. In Emery's study showed that peak isometric adductor torque in the squeeze test right there was not a risk factor. But we know from looking at several studies using this testing method that it's not a very reliable and valid way to test the strength there. And in their study, they had they had 28 NHL teams with 28 different testers. So there might be some dirty data there. Our study subsequently looked at one tester, me, and we looked at the way Christian tested the adductors in the sideline position there, and we found a significant weakness in players who sustained a groin strain. But what we found when we went inside the numbers was the best predictor of a future groin strain was the strength ratio of the hip adductor to abduction strength in that ipsilateral leg. In fact, the relative risk when the adductors were only at 80% as strong as the abductors was 17 times greater risk. And when we look inside the uninjured players, their adductor to abductor strength was 95% of their abductors. The injured players are only 78%. That's something that we use today, which we'll go over in a second, to help predict or to help us guide return to play. Christian also showed a similar race strength ratio in his soccer players, where it was predictive of pain-free hip testing. Now, despite the best prevention techniques, injuries do occur. And at our institute, we have to deal with these. possible mechanisms of these injuries for ice hockey players is that ice hockey involves the skating stride, where we lengthen those adductors strongly with those hip abductors and extensors concentrically, and to decelerate that leg, we need to decelerate that with our adductors and our hip flexors. The mechanism of injury sometimes is with a sudden external rotation force. The abducted leg in that lower extremity is at a very precarious position, and with just a little bit of extra force or a push from the upper extremity, you get a groin strain there. In football here in Europe and across the world, we see it a lot when the player goes to kick a ball and there's a sudden stop by a defensive player, and they stop the ball and you get a quick eccentric overload of those adductors in football. Now, no matter how it occurs, we need to deal with that, and we need to get that acute adductor strain back on the field. This is a Parahomich's study. It is one of the best studies I've ever read. It looked at passive versus active therapy. Passive therapy there, which we all use. And I'm not bashing passive therapy by any means. Certainly, we need to create a healing environment by using maybe some passive therapy modalities in our physio treatment areas. But then to get that person back, we need to follow what Christian put up earlier, and that's PAIR's active therapy protocol. I put up the study not to show you that I just don't read BJSM and AJSM. I read Lancet. There it is. Great. This great study looked at 68 patients, great outcome measures. You probably read. I know I'm going fast and I'm going through it, but I'm sorry I'm talking so fast. Take-home message on this study. Look at that. Active training. 23 of those athletes had excellent results. Passive training. 4 people had excellent results. Look at the poor results on the passive training side. In fact, it was 79% of that active training had no residual pain and return to sport. If you look at the passive training side right there, only 14% had no residual pain. That's some pretty strong evidence that we should start active training maybe as soon as possible to get these folks back on the road to recovery. Our philosophy in this mat is here. We'll start isometrically and we'll progress them to isotonic activities against gravity. Then we'll go isotonic against resistance, eccentric, and what we like to call functional eccentrics to prevent re-injury. We base it on the basic science. Any muscle strain, or especially the adductors, you get a gap in the fibers. A hematoma fills in. You get some regeneration here and some scarring. What happens is the scar is, in the first 10 days post-injury, is the weakest link. So we don't want to stress that scar. Passive range of motion beyond the physiological limit is not something that we should do as clinicians. There's some solid evidence on starting isometrics early and keeping what range of motion we have, not stretching, but keeping what passive range of motion we have. Day 0, we'll start submaximal isometrics in a pain-free manner in a mid-range, and then lengthening it out to a lengthened range on day 3. Then day 10, we can get into eccentrics if that athlete allows it and the pathology allows us to get going on eccentrics early. But take-home message for acute adductor strains: start early isometrics, maintain available range of motion, but do not stretch. Do not stretch. Don't pull that hematoma and that scar tissue apart. It looks something like this. We'll do modalities, some passive modalities in the first 48 hours, but then we'll start with submaximal isometrics. We'll start with a short lever arm there with a ball between the legs, and we'll progress with that ball to a long lever arm isometrically, always keeping the isometrics pain-free or minimal pain. From there, we'll keep what range of motion we have by moving the leg through its available range of motion, but not stretching it. We'll do some bilateral balance work in this first phase, and then we'll progress to phase 2. How do we know when to progress? We use clinical milestones. We don't say, oh, it's 2 weeks, oh, it's 4 weeks, oh, it's 10 weeks. Clinical milestones. So we'll look at the ability of that athlete to do a concentric adduction leg raise against gravity without pain. The time frame depends on the severity of the injury. Then that gets us into phase 2. And phase 2 is everything that we've all been doing. All of us in this room have been doing this stuff for quite some time. It's the ABA deduction machine, it's slide board, it's resistance, it's balance board, it's fitness stuff. What's our clinical milestone to get folks back through into phase 3? It's the involved lower extremity passive range of motion equal to that uninvolved side. But it's also the involved adductor strength, at least 75% of the ipsilateral abductors. We want to get that bias back, that ratio back as closely as we can. And this is one of our objectives for returning people to light skating on the ice. Now, phase 3 is what we call our functional eccentrics, and we'll do a lot of TheraBand roll work. We'll do functional eccentrics here. If we're doing that, that's probably the time for return to play. But that's kind of the philosophy. We'll increase in intensity and load, and that's based upon your clinical judgment. There's no exact science for that. Slide board for time. There's a lot of talk this morning about fatigue, and certainly we'll do time-based slide boards for these hockey players and these soccer players with trying to fight fatigue. Split lunges, some sports-specific type stuff. Ever try this? This is pretty difficult, trying to balance a board and a stick while rolling back and forth. Sports-specific sort of treadmill for a hockey player there. And our clinical milestone, and possible or return to play criteria here. We like to see the adductor strength at least 90 to 100% of the abduction strength. The involved muscle strength equal to that of the contralateral side on those adductors. We're looking at the ratio and the absolute strength, both. How long it takes, that's up for debate. Last couple slides is return to play. How do you really know when to turn we can look at the strength and all that, but how do you really know when to return these folks? We talked a little bit about the squeeze test. If there's any shot this is going to work, I have no idea, but here we go. Oh, yeah. So here's the squeeze test here. The squeeze test here, they'll squeeze that, and there's some clear disadvantages to doing that. You're getting a force there, but you're getting a force probably of both legs. And you can't identify which side is weak. You cannot get a ratio, and it's not validated. So we prefer the test. Where's that mouse? Hold on. Up there. Good. All right. With a handheld dynamometer like Christian showed there, where we'll bring it up, we'll stabilize, and give a force just proximal to the medial malleolus to get an adductor force. We'll do an abduction force test, and we'll calculate the ratio. And that's how we do the abduction test. And we'll calculate our strength ratios that way, being objective. But maybe we need to go something like this. You've also heard of Carl Askling and his work on the H test for the hamstrings. Maybe we need an H test for the adductors, where we have them throw their leg quite violently. On the good side there, you saw Juan Carlo there, and then on the injured side, he can't do that because he gets pain immediately in his groin. So maybe it's the H test. Or maybe it's the Copenhagen test, which was on the poster upstairs, which I enjoyed reading last night. That could be the return to play criteria. There's lots of protective devices and wraps. Take-home message is that rehabilitation, 1 to 2 days max, early active therapy. Use objective measures, not time, to return to progress. Don't return to play too early and complete the rehabilitation. In terms of return to play, maybe not wear edge spikes. Possibly increase adduction and core strength, restore adductor strength, maybe restore that ratio. And then maybe someday your country, like mine, can win one of these, or maybe even, you guys are going to win this. Thank you.